Hi, I'm Bob Falcone. I'm CEO of the Columbus Medical Association and its affiliates. One of those affiliates is the Central Ohio Trauma System. Central Ohio Trauma System has been integral to helping organize our COVID pandemic response. Today I have John Weigand with us. Dr. Weigand is the medical director of National Church Residences and the president of his group, which is a geriatric and palliative care group. Hi, John. Welcome.
Thanks for having me.
I think most practicing physicians don't really have much experience with nursing homes, and those of us that are hospital-based have even less. What are some of the differences that you might see in a nursing home or an extended care facility as opposed to a hospital system?
I think what I would probably say initially is that congregate care settings, for which nursing homes are one, but oftentimes get grouped in with assisted livings and a number of other settings where people live outside of the independent setting. Sometimes get grouped into that, and there are a variety of different ways that those function on a day in and day out basis. Obviously, they have different regulatory requirements. And as a result, there are different staffing expectations, different infection control abilities. And so, I think what I've learned over the course of the last several months is that understanding isn't really deeply held throughout the medical community. What the capabilities of some of these settings are.
So what we find particularly easy to do in a healthcare environment like a hospital, cohorting patients, testing regularly, having access to PPE, doesn't necessarily exist in nursing homes as we see them today.
Yeah, I think obviously the acute care environment has gotten a lot of the initial concern because that's where we expected all the COVID-19 patients to end up going, the ones who were sick, and obviously, we heard about it in China, we heard about it in Italy. We've certainly seen how it's affected communities, initially out west and then in New York and the like, and really a lot of the attention has been the movement from facilities into the hospital. And so, hospitals see it as, we're the stopgap, we're the last level of care, for extremely sick individuals. And, the nursing homes are the ones that, have been living with these individuals for perhaps years and caring for them. And oftentimes those are just the small minority of people that you see on TV. We've obviously have 960 some facilities, and that's just nursing homes in Ohio. And, they're a very small proportion of those have had, significant and widespread effect of COVID-19.
Yeah, as I understand it, there's about 1,000 nursing homes, and about 350 of them had more than one COVID-19 case. But we really haven't tested all those people, have we?
Yeah, I think that if you remember back in March, the biggest challenge was getting a test at these facilities. The option would be for them to send them to the hospital, to the emergency room, to be tested. That wasn't acceptable, especially if they were asymptomatic or mildly symptomatic. And the capacity for getting the testing swabs back in March, those were the commodity of the day. That was the challenging thing to be able to get. And so I think it's not so much that there aren't cases or there haven't been cases only in these 350. I think there's a viral load that in a closed environment like a nursing home or an assisted living, There's a viral load that when it hits a certain tipping point, it becomes readily evident to the nursing staff and to the administrators, and that's when they start, pulling the panic button or pushing the panic button.
So as the Chief Medical Officer for National Church Residences and really a liaison for many of the nursing homes throughout our region, which is central, southeastern, and southeast central Ohio, you've been knee-deep in representing these organizations in much of the Governor's Zone 2 work. You established something very early on called the PART program. Can you tell us about that?
Yeah, so actually National Church Residences is more involved with affordable senior housing. We do have some skilled nursing and long-term care, as well as assisted living. And so early in the pandemic, we had a case, a symptomatic individual in one of our closed memory units, and ultimately needed to get that individual tested. And through a series of 6 or 8 phone calls, I was finally able to figure out how to get the person tested. And I had a swab. Dr. Thomas, CMO at Ohio State, was able to get me a swab. So I had a swab. I didn't know what to do with it, essentially. So, so that was probably the initial genesis of this idea of the PART program. From there, though, I had been in collaboration, communication with my colleagues out west through various Zoom meetings and the like. And one of the things that they said that was sorely missing in their communities was a way to test in nursing homes, in assisted living, in congregate care settings. And so, I brought that to the attention of the leadership at National Church Residences, which is located, their headquarters are right here in Upper Arlington. And brought this to their attention, and they said, well, what is it that we can do to change that? And so we came up with this post-acute regional rapid testing program.
PARRT.
2 R's, yep. And ultimately, set up within a week a call center. We already had a call hotline, which was really set up primarily for National Church Residences. We're in 25 states, have over 25,000 seniors living under our roofs any evening. And so, all those people were calling this this COVID hotline that we had already set up. And so we just had a couple individuals who served in the call center for the PART program. And a facility would have one number to call. Then we would connect with the Ohio Department of Health, which at that time had a limited number of approved tests per facility for epidemiologic standpoint. And so we negotiated all that, basically communicated with the local health department, all while we dispatched a swab team, which was made up of Medical Reserve Corps individuals from the local health department. Didn't even know they existed before COVID. And we were able to train that contingency of volunteers down at Ohio State at their drive-through swab center. And within a week got this program up and running, and did our first swab on Easter Sunday. We were going to do a soft launch in Franklin County. Actually, our first swab was in Licking County, but we went ahead and took it anyway, and we've done almost 3,000 now.
What have you found?
Um, I think we found some deep learning, and initially that there's some benefit in doing index case testing. A patient or resident that a facility may suspect has COVID-19. So we're able to go in and do that test quickly, get it to Ohio Department of Health. They identify if it is or not. Once you find that there's one or two within the facility, which have been closed ecosystems now since early March. So really the only way that most likely could have occurred is for the staff to have inadvertently brought it within the facility. And then that has really led to the second kind of generation of, okay, we're going to test the residents. Now we could go in and test every resident, but in a time of not having enough swabs or a reagent at the labs, we had to be focused about that. So we kind of had this strategic focused strategy for managing that. So we would test the unit, for example, if they were both on the same unit. If they were on separate units, and we could figure out through contact tracing that it was most likely due to a staff member, we would do, broaden the search a little bit. And so we started doing this expanded cohort testing, which allowed us to get a really good view into the facility where the COVID-19, what I call COVIDity, exists. And that allowed us to do what cohorting indicates, separating the negative and the positive, and trying to, flatten the curve within the facility, if you want to use the vernacular that has been so commonly used in the state of Ohio and elsewhere. So,
Well, at least from my viewpoint, the curve has flattened in our congregate care areas. But we don't really know the denominator yet, I don't think.
You don't. And I think to some degree in these facilities, as I kind of alluded to, I think there may have been cases, onesie, twosie cases that were asymptomatic, if you will. Never got to that kind of critical threshold of viral load within them, and they kind of burned themselves out or whatever. I think the third kind of level of testing that we've figured out relatively quickly is you have to test the employees. And obviously that's the strategy that the state is going forward with initially, soon to be involving the employees, and where there's been positive cases within residents, the 350 that you talked about. We're going to try to strategically go in and determine the amount of involvement within those resident populations.
Yeah, the governor, as you mentioned, has asked us to begin testing nursing home employees and the people living there. And at least in Columbus and contiguous counties, PART is established and I think very effective. I know you've been working with other counties to help them develop similar programs. Outside of Zone 2, which again is central, southeastern, and southeast central Ohio, the governor is using National Guard. How is that working?
Well, they started last Thursday, I believe. So, they're building in their experience of, kind of learning a little bit as they go. Started the first day with 2, I think, and then and those were here in Zone 2. And the National Guard is doing that testing as well, the employee testing. They then on Friday did 2, I believe, in each zone, so they did 6, and now they're really kind of ramping that up this week and next week. And I think it's too early to know all the bumps in the road and everything, but I think we had some conversations over the weekend that indicated that there were some opportunities to improve on just the communication and how we can smooth that out. And there was a large webinar that went on earlier today that addressed all the facilities that are going to be affected with the testing. So, I think the state is really trying to put their best foot forward and trying to think about this, trying to be clinically appropriate and not reflexive, but what is it that we can do within the realm of testing? We don't want to overwhelm our labs, who are also trying to open up hospitals a little bit more. They want to try to support the hospitals, surgeries and those types of things. Well, the hospitals are doing testing prior to those procedures. So, I think they have been listening to the needs of the physicians and the facilities. Anytime you move from voluntary to mandatory, that sets a different tone. But I think that they're doing it in a way that at least provides opportunity for feedback and improvement as we move forward.
Well, thanks to you and our other leaders in our zone and the incredible cooperation between facilities, many of whom are competitors, I think we've been ahead of the curve. It looks like we're going to stay ahead of the curve. What do you see will change in our congregate care facilities going forward after the pandemic settles and we're back to some sense of normalcy?
I think when will we be over the pandemic? That's the big question. I think we're looking at months and perhaps years before we're really done dealing with the immediate issues that are going on within congregate settings. Obviously, right now we're dealing with nursing facilities. The assisted livings have not really had the attention placed towards them in regard to testing. Now, interestingly, we're starting to try to open up visitation. And while we're focused on nursing facilities, the visitation is really being looked at in assisted living. So there's some potential issues that might arise in that, just because the assisted livings tend to not have as much staffing. They're not as tightly regulated as nursing facilities are. And there is the potential of obviously introducing COVIDity into assisted livings when you start allowing outdoor visitation. So I think we have some time to kind of look at this relatively carefully. But I think as we've opened up society, we haven't yet understood the effect of that. And obviously, when there are swimming pools in the Ozarks that are starting to demonstrate that there perhaps were exposures in those newsworthy settings, we're still going to get an idea of what this surge perhaps might look like even in 2 weeks or 3 weeks. And then again next fall, I suspect. And we'll continue to have to assess that. To get to the core of what I think your question was, though, I don't think nursing facilities or even assisted livings are going to ever be the same as what they were prior to this pandemic. The business structure, and I'm not an owner of these facilities. I'm a physician who goes into them and tries to provide good care in those settings. The business model for those are pretty tight. And any facilities that, for instance, have semi-private rooms, I think that's going to be perhaps a thing of the past. Having two people living in one kind of shared room, if you will, just from an infection control standpoint. The reimbursement models. I mean, we're spending a lot of money as a country, and Medicare and Medicaid are the funding sources for all of these facilities, and so how that affects the bottom line of all the facilities, I think, are going to be far-reaching.
Well, thank you. Until next time, this is Bob Falcone, Columbus Medical Association and Affiliates. My guest has been Dr. John Weigand, the Chief Medical Officer for National Church Residences. Thank you, John.
You're welcome.